So good morning. Once again, my name's Elsa Barnardi. I'm a psychiatrist and I'm clinical director for the Central Coast Mental Health. For those of you who are new this morning, welcome. For those of you who were there last night for a most interesting set of speakers, welcome back again this morning. I acknowledge the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and community. I pay my respects to them and their cultures and to elders both past and present. We also want to thank and acknowledge all people who have a personal experience of suicide. The voice of people with lived experience is essential in the development of our work. We acknowledge that behind every statistic covered in this presentation is the loss of human life and an impact on loved ones. I want to thank those who helped in particular in developing important parts of this conference and our safety plan, which we will be presenting, or Michaela Skopik will be presenting today, and that will be the practical part for those GPs who were asking yesterday evening, what are we doing about it? Today we have more practical sessions on safe side training and also on safety plan, and there will be a number of breakout sessions. So the program for the conference can be found on the website. The presentations will be recorded. There's an expo in the foyer, fire exit know about, question and idea, cards on the tables, and the conference organisers are wearing the orange lanyard, this one. Mid-morning breakout sessions will include the safe side and safety planning options and a brief description of what people can gain from each session. The GP one looks like being the big one, not surprisingly, and I'm glad it is a big one, so you stay in this room. The afternoon sessions will be the general practice, priority populations and young people. We are very pleased to welcome Phil Boyce back this morning, but before I do that, I'm going to do a very brief introduction because you won't want to hear me, but so we'll be very brief. So thank you again to the New South Wales Ministry of Health and Hunter New England Central Coast Primary Health Network for contributing funding and the LHD and PHN for organising and coordinating the event. Shall we move on to practicalities? Just a little bit, very little bit feedback why we're doing this now. Towards Zero Suicides, it's an $87 million involvement over 3 years, so it's a federal initiative. And there's a strategic framework for suicide prevention in New South Wales of 2018 to 2023. We contribute to the Premier's priority, and that is to reduce the rate of suicide by 20% by 2023. On the coast, I think we have not the highest in New South Wales, but the second highest. This is not something any of us like, and anything we can do to bring that down is a win. The Towards Zero Suicides initiatives seek to provide the leading best practice in crisis care and support, build on local community resilience and improve systems and practices to reduce the suicide. So very little on this stuff, but just so you get a context. The first national Suicide Prevention Advisor is Christine Morgan, who reports to the Prime Minister. So it tells us that this is something that has import at the federal level. Reducing the risk of the kind of distress that leads to suicide and self-harm means keeping people healthy and connected with communities and tackling the social reasons for suicide. Because as we said last night, we can deal with the psychiatric side, the general practice side, but the social reasons for suicide need to be addressed at a bigger level. So we're not addressing that, but we are attempting to address those ones that come to our backyard, as it were. Making sure people who find themselves in distress get immediate and effective help, that's what we're trying to do. Finding ways to connect services and empower all of us to recognise and respond to people in distress and instil hope. Hope was a big theme of Ken Nunn's talk last night, an incredibly important theme. Now let's look at some practicalities. Disturbingly, adolescents are now presenting to the ED increasingly with suicide ideation, plans and actual attempts. Now, this is an old study in the AMJ, but it's which compared recent presentations, and there was 50% increase since 2008 that looked at over a decade. There is more stuff coming out, however, to show that since COVID, there's been another 10 to 20% increase. There's a couple of comments that I just wanted to put up. I won't put his name up for too long, in case I've upset some people. But the comment in The Guardian, when he was interviewed about the new initiative for suicide prevention, I thought he made some very salient points. The government needed a plan and a budget to fund services for people who were suicidal from the moment they sought help, whether that was through a GP or an emergency department. Currently, there's little or no follow-up of patients who are suicidal after they are discharged from hospital, which means it is impossible to know whether people received quality ongoing care and support that would be essential to suicide prevention. This follow-up care and access to community care services needed to be funded and prioritised. He says, and I think there's some truth in that, there has been so much emphasis in the past on access to care, on that assessment, but we haven't emphasised the quality of the care that happens afterwards. More frighteningly, if you read any website about suicide prevention lines and that, and maybe American websites more so, but people will say that they don't get the response they would like to get from those call centres, that they often feel it's parroted, the response, and that people are poorly trained. Those are disturbing things to hear from consumers. So there's no doubt that we've got huge room for improvement. Our demographics on the Central Coast are particularly complex. A mixture of retirees, young families and sadly younger children presenting with suicidal ideation. We have an Aboriginal population. We know that the rate of suicide is higher in the Aboriginal population. Anytime you talk to someone of the First Nation people and they tell you their story of their lives, and you kind of go, oh, wow. You know, how many family members have died from suicide, how many family members have died from prematurely, from other illness, and it's quite in your face, I suppose, is one way of putting it, because it is just so many of the histories are so littered with tragedy. We have pockets of social disadvantage with a higher rate of drug use and crime in certain areas, particularly in the Wyong area. Drugs most often used are obviously alcohol, but look, ice is an enormous problem in regional areas. I just don't get it why that's not so often seen in Sydney. If you talk to people who work in Sydney, yeah, they'll know about ice, but they don't know the level of problems it causes. It is a regional problem that's devastating regional communities. These are interesting times to roll out suicide prevention strategies. We had an idea. In 2019, as I mentioned last night, I'd heard about a little bit of, let's call it serendipity here. My daughter is a clinical psychologist who was working on the Gold Coast on the crisis teams there. She was ringing me from time to time, as daughters do, you know, anybody got a daughter here, you'll know what it's like, kind of to debrief and to tell me what she'd done for the day. And she was giving me a rundown of who she'd seen and how she'd assessed that patient with suicidal behaviour. And I'm going, you're doing a better job than a lot of my registrars. Not because I'm a proud mother, because I'm, no, maybe a little bit. But anyhow, I said, how come? And she'd been trained to do these safety plans, and the Gold Coast had got their act together and were rolling out a program which was changing the culture and changing the statistics with a reduction of 30% of presentations to the ED. So I said, I've got to go and see this. So end of 2019, I think Kath Turner, the lead there, very kindly let me go and talk to them over the Christmas period, as I was up there anyhow. And I thought, this is worthwhile doing. Now, they've published in Australasian Psychiatry recently, because they've done the stats a bit quicker than I think New South Wales managed to do them. And Victoria got in with us ahead as well. So very quickly, we know already that for self-harm and attempted suicides have increased by approximately 20% post the COVID. So that means they've got more challenges again. Previously, approximately 20% of the population sought help. Now an additional 5 to 10% want help. Sadly, 20% are not getting help. So that is, they can't get an appointment with a psychiatrist, definitely. They can't get an appointment with a psychologist. The waiting list for psychologists is now 3 to 4 or 5 months. Many psychiatrists have closed their books. Now, publications in the Australasian Psychiatry also demonstrate a surge in presentations. But interestingly, fewer Aboriginal coming through the ED. And with the thought being that perhaps because they're scared of COVID, who knows, but we are going to be missing this population, and that's an important thing for us to note. To summarise then, they looked at who is most vulnerable to poor mental health. Bit of a surprise here, or maybe not. Senior citizens, healthcare workers. Now, is this because of what happened during COVID with healthcare workers? Perhaps. Carers and parents, perhaps not so surprising, with kids at home and the service of the elderly disappearing for a while. People with existing mental health conditions, not surprising either, because I think our services condensed so much during that period that we saw it on the coast, that the people presenting with mental illness post the COVID restrictions being lifted were far more unwell. So it suggested they weren't getting the follow-up and getting what they needed during COVID. Young people, no surprise there, but increased younger people. It says 18 to 24, but it actually should be 14 to 24. Disturbingly, we get phone calls. The registrars here are often having to see 12-year-olds, 14-year-olds, 10-year-olds with suicidal ideation. I'm about to finish and open it up to the good speakers. Today we will deal with managing depression, but bipolar rather, and for training for suicide prevention. Last night we were lucky to get an overview of the guidelines for managing depression. Today we'll be lucky to get an overview of the bipolar guidelines. We hope that the Gold Coast service is going to help us, because there are elements of that model that New South Wales is actually adopting, and they reduced their presentations by 30%, as noted. In brief, their strategy is screening and engagement, which identifies the best way we can engage our patients and detect, or I think we kind of do that all right. Assessment, approaches and techniques to enhance the identification of suicide risk. That's something that I think we can train up better in. Risk formulation, that's the big thing. We have been doing tick boxes for suicide assessment mandated by New South Wales Health for a long time. I think it's been a failure. People can't be reduced to tick boxes. I think we need to understand the person in a context of their background, their family. We need to improve the synthesis and quality of information to improve treatment planning. Initial interventions, safety planning, this is a big one. And we'll have a clip from the Safe Side person from New York. We're lucky to get a clip from him to help us with this talk, because it's such an important international movement. Structured follow-up. Now that's, I think, an area we need to improve on. And transitions of care when they can go back. Our first step is to develop the safety plan. Sounds easy, and has had input from multiple people, including those with lived experience, and it's ready to go. Not as easy as you'd think. You know, you've got a number of safety plans out there, you pull them together. One of our managers, Child and Family, Catherine Marilla, was on the state committee. They pulled it all together. We put the modifications in. We've got input from people with lived experience. Then it goes to the forms committee. 2 or 3 months before we can get it barcoded. So we can't use it until it's approved. And I'd like to say that's great news. It's through, it's barcoded, it's ready to go, which means it'll go into the electronic medical record. We'll be able to pull it out to give to patients when they leave, for them to take it to the GPs and to take it to the families. Finally, a comment from the lived experience perspective of suicide published by the Black Dog Institute. I think it's great. Helpful responses are those that see our humanity, offer time and a safe space to be deeply listened to and validated, provide genuine compassion, free of judgment and agendas. This empowers a person to find their own meaning and the answers to problems in their own life. It's my great pleasure to start the day of training with an overview of the evidence base for management of bipolar and to reintroduce Professor Phil Boyce. For those who weren't here last night, he is Emeritus Professor of Psychiatry, University of Sydney. He has a clinical and research interest in mood disorders, particularly in the management of bipolar disorder over the perinatal period, and research into the triggers for bipolar relapse. He's been a member of lots of working groups that developed and updated the Royal Australian New Zealand College Psychiatrists' Mood Disorders and Clinical Practice Guideline, and also the Clinical Practice Guideline for Anxiety. He was president of the Royal Australian New Zealand College from 2003 to 2005, and president of the International Marseille Society, which focuses on perinatal mental health from 2002 to 2002. He is an associate editor of the Australian and New Zealand Journal of Psychiatry. We are indeed fortunate to be able to welcome him to explain how to manage bipolar disorder. Thank you.